Everyone. My name is Iyana Jesu. I'm a third-year psychiatry resident. Today I will be doing my PRITE review on addiction psychiatry. And so we're just going to get right into the questions. Okay, so question 1. A patient with comorbid addictive illness and social anxiety disorder discusses with the psychiatrist the painful experience of anxiety when attending the first AA meeting. Which of the following statements by the psychiatrist will be consistent with a 12-step facilitation therapy? Option 1, do you feel like drinking when you get anxious? Option 2, what thoughts do you have when you imagine entering a group of strangers? Option 3, how did you master your social fears when you went to church last Sunday? Option 4, you did the most important thing, you went to the meeting, it will get easier. Option 5, maybe meetings are too anxiety-provoking at this stage. Let's work on mindfulness. I'm going to launch the poll. I don't know, can everyone see the poll?
Yeah.
Okay. I'm just gonna wait a couple more seconds. Okay, gonna end the poll now and share the results. So about a little bit over half of us, agreed on one thing. Seems like we are split with the others. Minimize this. And so the correct answer is D. You did the most important thing. You went to the meeting, it will get easier. So this is actually talking about 12-step facilitation therapy. It's a type of semi-structured therapy for people with substance use disorder that the aim of this therapy is just to encourage the patient to join 12-step organizations. So essentially, everything you're doing, you're trying to encourage the patient to attend meetings. You're supporting them, you're validating them to tell them, okay, just go to these meetings and that's how you're going to get better. You're helping them to develop support networks. You're helping them to address barriers. You're educating them about what 12-step program is. And if we look at all of the options that we had, the only option that is essentially encouraging this person to keep going to meetings is, you did the most important thing, is telling him going to the meeting is actually the most important thing, and you went to that meeting. It's going to get easier as you keep going. All the other options do not encourage going for, continuing to go for meetings. Okay, so the next question, question 2. A physician recommends that an outpatient start buprenorphine for opioid use disorder. The patient admits to last using heroin an hour before the appointment. The physician should initiate buprenorphine A, after a negative urine toxicology test, B, when acute intoxication has worn off, C, while the patient is acutely intoxicated, D, when the patient is experiencing mild withdrawal, and E, once the patient is no longer in withdrawal. Okay. Okay, so just gonna wait for more people. Okay. All right. I'm gonna end the poll now and share the results. Okay, so well, most people picked option D, and then we had a few splits. The correct answer is option D, when the patient is experiencing mild withdrawal. So like most of us know, buprenorphine is a partial agonist at the mu opioid receptor and also at the kappa opioid receptor. Now, buprenorphine has more affinity for the mu opioid receptor than the full agonist, in this case, heroin. And as such, it will displace heroin and will lead to precipitated withdrawals. And because you want to avoid this, the consensus is to wait around 6 to 12 hours after the last dose of full agonist before you start buprenorphine. So the patient will be in some withdrawal, and then you start buprenorphine, and buprenorphine will actually help to alleviate some of the symptoms of withdrawal in the patient. So next question. A 21-year-old patient is brought to the ED after having an episode of nausea, sweating, and hematemesis. The patient reports recently having severe headaches and numbness in the extremities. CT scan shows generalized brain atrophy. Laboratory studies reveal evidence of renal tubular necrosis and CPK of 3,120. This presentation is consistent with chronic use of what substance? So we have PCP, that's phencyclidine, amphetamines, steroids, cocaine, and inhalants. Sorry, trying to share the poll. Okay. Just gonna wait a few more seconds. I'm gonna share the results. So most of us actually got this correctly. The correct answer is inhalants. And I'm just going to go over the chronic effect of some common substance. So for PCP, that's phencyclidine, you can develop cardiac arrhythmias. You can actually develop different cardiac complications because it would increase blood pressure. It can cause depression, can lead to seizure disorders. It can lead to acute and chronic psychosis. It can develop speech difficulties, sometimes develop like slurred speech. They can develop memory loss, and they can develop loss of fine motor skills. Amphetamines can lead to damage to the medial temporal lobe, the cingulate limbic cortex, and also they can have white matter hypertrophy, psychosis, and depression. Chronic use of steroids can lead to, and for this is, for steroids, it's actually using more than physiological dose that would lead to this chronic side effects. So they can develop cardiomyopathy, kidney failure, stroke, psychosis, and also aggression. Cocaine can cause stroke, heart attack, hemoptysis, and for our question today, inhalants. Inhalants can cause severe headaches. You want to remember that inhalants can cause generalized brain atrophy. And so in a young person, the person might actually develop symptoms consistent with dementia. It can lead to numbness in extremities, rhabdomyolysis, which is why the CPK was elevated in this patient, and also tubular necrosis. So next question. Which of the following, oh, sorry, I think, yeah. Which of the following is a primary mechanism through which amphetamines exert their stimulant effect? So one is release of catecholamines, B is blockade of GABA receptors, C is blockade of monoamine reuptake, D is blockade of catecholamine reuptake, and E is amino acid neurotransmitter. Just waiting a few more seconds. Okay, need to end the poll now. I'm going to share the results. So almost everyone got this correctly. I think I accidentally showed the answer to this before we took the poll. And the correct answer is A, release of catecholamines. So I'm just going to go over the primary mechanism of some of the common drug of abuse. And so here we have alcohol. Alcohol works on GABA, is a GABA agonist and a glutamate antagonist. Benzos and barbiturates, they work on GABA. Opioids, the opioid receptors, the mu receptor, kappa receptor, and delta receptor. Cocaine will block the reuptake of monoamines. So serotonin, dopamine, norepinephrine. Methamphetamine, like a question for today, will enhance the release of catecholamines, mostly norepinephrine and dopamine, but to a lesser extent, it also enhances the release of serotonin. For ecstasy, blocks the reuptake of serotonin and dopamine. PCP is an NMDA antagonist, as is ketamine, and marijuana stimulates CB1 and CB2 receptors. So if we look at our question for today for the stimulants, you see that there's release of catecholamines and there's blockade of catecholamine reuptake. So what amphetamines do is they release catecholamines, and it is cocaine that blocks the reuptake of catecholamines and serotonin. Going to the the next question. Caffeine results in dopaminergic activity where? So, Going to wait a few more seconds. Okay, so 85% of us got this correctly. Great job, everyone. So I'm just going to talk a little bit about caffeine as a drug of abuse. The correct answer is B, adenosine receptor. So caffeine is a wakefulness promoter. It's also a mild cognitive enhancer. It acts on adenosine receptor and causes release of acetylcholine. It also stimulates catecholamines and serotonin, but its major primary mechanism of action is it works on adenosine receptor. So caffeine use disorder is being considered to be added to the DSM-5, and so I'm just going to talk about some high yield things when it comes to caffeine. You want to know the signs of caffeine intoxication. So typically, they will probably tell you about a patient that is really under a lot of stress, maybe working a high pressure job and needs to stay awake. And the person is presenting with restlessness, nervousness, excitement, insomnia, flushed face, rambling flow of the speech, psychomotor agitation. So depending on the options that you have, you want to keep caffeine intoxication in mind. Some other higher things about caffeine is the withdrawal symptoms from caffeine. So usually a patient that is having insomnia is having restlessness, having difficulty concentrating, and then is having headaches. The most common symptom is headache. Remember, caffeine headaches. And so you want to think of caffeine withdrawal in a patient like that, or in a scenario like that. Another high yield thing is a treatment for caffeine use disorder. You want to cut back on caffeine slowly. They typically say about 25% per week. And another high yield note about caffeine is it's the most common mood altering drug in the world. So if you have that question, you want to remember that. So moving on to the next question. Which of the following compounds demonstrates promise as a treatment for relapse of methamphetamine abuse? Option A is bupropion, B is lithium, C is paroxetine, D is lorazepam, E is risperidone. I'm having some difficulty. Oh, okay, launching this one. Okay, yeah, I think I've been able to launch it. Okay, so almost everybody got this correctly. Great job. The correct answer is bupropion, and this goes back to the mechanism of action of the primary mechanism of action of methamphetamine that we talked about. It causes release of catecholamines, and bupropion is a norepinephrine and dopamine reuptake inhibitor. And so because of that, it's thought that this might be helpful. I'm just gonna go over some other high yield things when it comes to medication management for substance use disorder. So for example, starting off with smoking, the strongest evidence is for varenicline, which is Chantix, as the treatment for smoking cessation. Another option is bupropion. However, for the purposes of this exam, Chantis has the strongest evidence, and it actually binds to nicotine receptors. Bupropion, it's unclear the mechanism of action for smoking cessation, but it's thought to have some nicotinic acetylcholine receptor function, and also seems to have some effect on withdrawal symptoms from smoking. Now, if the question has bupropion plus group therapy as an option, then together, bupropion and group therapy actually show more evidence for smoking cessation. And then for opioids, we already talked about buprenorphine already. Methadone is a full agonist, and it does not require the person to be off of opioids for a certain number of time before you start it. Naltrexone is an opioid antagonist. And then for alcohol, we have naltrexone, we have acamprosate, we have disulfiram. Naltrexone, like we all probably know, you want to check like liver function before you start it. For acamprosate, the mechanism of action is unclear, but it's thought to act on the glutamate receptor. We're going to talk a little bit about the reward pathway as we go on in this presentation, but for now, we just need to know that it works on the glutamate receptor, and in that way, it helps in the reward pathway to prevent alcohol use. Disulfiram is not used as much because it inhibits aldehyde dehydrogenase, and so it prevents the breakdown of acetaldehyde. And so this leads to symptoms of nausea, vomiting with alcohol intake. Okay, so next question. A state of general fatigue, need for sleep, and depression may be seen during a patient's withdrawal from A, alcohol, B, PCP, C, cocaine, D, opioids, and E, LSD. Okay. And then almost everybody also got this question correctly. The correct answer for this is cocaine. I'm just going to talk about some common withdrawal symptoms that we have for different, some common drug of abuse. So we have heroin and opiates in general. You have nausea, vomiting, diarrhea, trouble sleeping, goosebumps, hot flushes. And then for alcohol, depending on how long after alcohol intake, you have tremors, anxiety, depression, tachycardia, dilated pupils, nausea, vomiting, agitation, hallucinations. For cocaine, you have fatigue, you have depression, you have increased appetite. And then for cannabis, you have sleepiness, irritability, and reduced appetite and anxiety. And it's just gonna go over the alcohol withdrawal timeline. This is something that they typically ask on the PRITE. So the first 6 to 12 hours, you have minor withdrawal. So you have tremor, sweating, anxiety, tachycardia. And then 12 to 24 hours, you could have alcoholic hallucinosis. 24 to 48 hours is when you you could have seizures, and after 48 hours is when you have delirium tremens. So we're going to move on to the next question. Which of the following areas is most consistently associated with the reward effect? So is it the amygdala, the locus coeruleus, anterior cingulate, mammillary bodies, or the nucleus accumbens? Okay, great job, everyone. 85% of us answered this correctly. So before doing explanation on this, the correct option is nucleus accumbens. Before I do an explanation on this, I will launch the next question and then I'll explain together. So which of the following neurochemicals has a major role in the acute reinforcing effect of drugs of abuse? The cortisol, dopamine, nitric oxide, epinephrine, and substance P. Just a couple more seconds. Right, so everyone that answered is in agreement for this one, and the correct answer is dopamine. So I'm just going to talk a little bit about the mesolimbic dopamine system, the reward pathway. And so usually when there is a stimulus, so for example, food, or drugs of abuse, alcohol, opiates, what happens is that the dopaminergic neurons that are in the ventral tegmental area, they are stimulated, and dopamine travels from the VTA to the nucleus accumbens, and then also travels to the prefrontal cortex. Now, in the nucleus accumbens, you get euphoria from the feeling of euphoria from the drugs. And in the prefrontal cortex, you get the behavioral changes that you get from the drugs. And usually you have some neurotransmitters that are released. For example, for alcohol, you have GABA is increased, you have dopamine, you have serotonin, you have opioid, you have acetylcholine. Now, glutamate is reduced with alcohol intake. And then with prolonged use of a drug, there is a new baseline for all of these neurotransmitters. And so that's when the person develops tolerance. And for him to get that same effect, they have to increase the amount of the drug they are taking. And withdrawal happens when you take the drugs away, and then these neurotransmitters that were previously increased then go down, and this leads to the symptoms of withdrawal, cravings, and drug-seeking behavior. Something else that I wanted to just quickly go through was for question 8. The amygdala essentially is involved in emotional response, so like fear response. The locus coeruleus releases norepinephrine and modulates arousal and sleep, modulates your memory, adds some sensory processing. The anterior cingulate ups in like decision making and also pain perception. And then you have the mammillary bodies. They function for recollective memory and spatial memory. Okay. So for next question, which drug of abuse is associated with bruxism, anorexia, diaphoresis, decreased ability to orgasm, and hot flushes? Just a few more seconds. In the form. Okay. So we're a little split on this one, but a little more than half of us got the answer correctly. It's MDMA. Just gonna do a quick review of clinical features of the hallucinogens. This is something that PRITE ask a lot. So the first thing is all of the hallucinogens have sympathomimetic features. So there's increased blood pressure, there's increased heart rate, they suppress appetite. Now, of all of the hallucinogens, PCP is the only one that causes meiosis. All the other ones, LSD, mescaline, MDMA, we call mydriasis. Specifically for MDMA, you want to remember that it causes bruxism, that's teeth grinding, it causes rhabdomyolysis, and also you want to remember that it causes hyponatremia. This is a question that you can get about what electrolyte disturbance can you get from MDMA. PCP would cause nystagmus, hypertension, because of the sympathomimetic effect. So you want to remember PCP is the only one that causes meiosis, and it would also cause nystagmus.
So he missed his intake.
Yeah, his psychiatric intake, they just scheduled it for the 13th of
Mark, please mute yourself.
Mute us all. Thank you. So GHB, that's gamma hydroxybutyric acid, it will cause euphoria, it can cause peripheral vision loss, hallucinations, vomiting, slowed breathing, sudden loss of consciousness. So this is very specific because of the peripheral vision loss. So if you get a question where somebody used the substance and they now have peripheral vision loss, you want to think of GHB. Hey, next question, 25-year-old patient without any psychiatric history is brought to the emergency department by the police. The patient is nonsensical. The patient is yelling, assaulting guards, and has vomited once. Heart rate is 135 beats per minute. Blood pressure is 155/80 milligram of mercury, and temperature is 101 degree Fahrenheit. Urine toxicology is negative for opioids, cannabinoids, amphetamines, and benzodiazepines, and the blood alcohol level is 0. The psychiatrist suspects intoxication with bath salts. Which of the following is the most appropriate agent to use at this time to control agitation? Gonna wait a few more seconds. Okay. About 78% of us say that the correct answer is 78. A few of us think it's Haldol. The correct answer is, in fact, lorazepam. So I was just going to go a little bit over medication for agitation, especially as regarding to substance use. So when it comes to substance use, especially for the PRITE, the correct answer is usually benzodiazepine. However, for PCP, especially when they say that the patient is having hallucinogens and they mention that the patient has used PCP, the answer is usually an antipsychotic, typically Haldol in the option. And for PCP, that's because they get very violent, and I've seen questions where they said, what is the one thing you don't want to do with PCP patient? And that's like, you don't want to verbally de-escalate at all for PCP patient. So you can use combination of Haldol and lorazepam, or for this patient, or just Haldol by itself. And so so that's just that's one thing to keep in mind. For substance in general, you want to use benzodiazepines alone, except for if the question asks about PCP. And then this is the last question. For how long after use does alcohol remain detectable in urine? Is it 6 to 8 hours, 12 to 48 hours, 5 to 7 days? Is it that alcohol cannot be detected in urine? Just gonna wait a few more seconds. Okay, so we are a little split here, but still more than half of us think it's 12 to 48 hours, and that is in fact correct. So it's 12 to 48 hours. I was just going to just talk about, so alcohol can be detected in urine, in breath, in blood, in hair, and in saliva. For urine is about 12 to 48 hours. For breath is 24 hours. For blood is up to 12 hours. And for hair is between 12 and 48 hours. And the longest is in saliva. You can stay in saliva for 1 to 5 days. But you want to remember that the amount of time for detection is going to depend on the body mass of the person, the type of drug, the amount used, the frequency, and also that person's tolerance. So this is just a table that is showing how long after taking a drug the test continues to be positive. So for example, cannabis, here it says 1 to 7 days, but for somebody who uses sport chronically, it can actually be up to a month. And then you have cocaine that is 2 to 3 days. So you just want to review this table before PRITE to have an idea of how long some of this urine tests stay positive after using. And that's my last question. Thank you very much for listening. I'm going to turn this over to Dr. Led in a minute.
Hello.
Hi, sorry, I'm gonna make you a co-host now.
Mm-hmm.
Okay, I think I just did that. Stop sharing.
Okay. Oop. Okay. I just had a brain fart.
Yeah, you should see it on the bottom right corner where there is like a zoom thing. The one right next to the minus sign. Yep,
Mhm.
presentation mode, bottom right corner. The one on the right to that, yep. Right
This?
there. No, not this.
Looks like a projection screen and it's right by the,
Yeah, that's it.
Thanks. Yeah, I just had a brain fart. I don't even know why.
No problem.
Okay. All right. Can you all see that well?
Yep.
Okay. Okay. So here's my first one. The parents of a 12-month-old child are concerned because they are not walking yet. The child can sit up, crawl, and hold a stand, but cannot cruise. Oh, hold on. The birth and medical history are unremarkable. How should the physician first respond to the parents? Where's the poll? There it is. Okay. Okay, why is it not letting me launch it?
did IJX out of it?
Oh, now it worked.
I think
Okay.
you should be able to do it.
Okay, can y'all see it now?
I don't.
Oh, there we go. Okay. There we go. Okay. So, okay, so the answer is that the parents should be reassured that the child is developing normally, which surprised me a little bit, but you know. So for child and adolescent psych, develop on the PRITE, development is important. Knowing when, like, that chart you just have to memorize: motor development, sensory development, language development, all of that. It's honestly kind of something that you kind of just have to memorize. But for motor development, it's 9 to 12 months. They learn to stand alone, move using support, maintain balance. So it's okay if they are not walking yet. That doesn't mean that they are having any sort of developmental issue there. Okay. Question number 2. A 4-year-old child that lacks which of the following motor skills would be most concerning for a developmental delay? And there's A, copies a circle; B, throws a ball overhand; C, brushes teeth; D, hops on one foot; E, rides a bike without training wheels. And so that this is if they can't do this, which is concerning. Okay. So for this one, yeah, I kind of got mixed results. And like I said, honestly, these type of things are just, you got to memorize it. It's annoying, but you had to do it for our pediatrics boards and all of that. So, or shelf. So, but the answer is copies the circle. One trick is that they can like do a circle at age 3. I think it was like a triangle, age 5 or something like that. So again, milestones, just kind of a chart you got to memorize. Age 4, yeah, copies, or age 3, they should be able to copy a circle. Age 4, they should be able to copy and draw a person with 3 parts. Age 5, they should be able to copy a square. Age 6, they should be able to copy a triangle. So I remember what I was going to say is that I remember learning tri-circle. So like 3 and being able to copy a circle. But it's kind of just something that they ask about, and that you got that is just kind of more memorization. Okay. Question number 3. Which of the following is seen most frequently as a comorbid condition in children with autism spectrum disorder?
Right.
Okay. So this one was very mixed, but the answer is intellectual disability. So what makes this question difficult is all of these are seen more frequently than control and autism disorder, but intellectual disability is the most common. As of the most recent prevalent study conducted by the CDC, which studies records from 2008, 38% of children with autism spectrum disorder had intellectual disability, making it the most frequent comorbid condition of the options presented. And like I said, most of these have increased frequency, like ADHD. They often show elevated traits and have overlapping symptoms. OCD is like shown to be very connected to it. And early onset schizophrenia. I mean, we've seen like, you know, in 3 North, you have patients who have, you know, autism, and then they end up developing bipolar disorder or schizophrenia sometimes earlier. So all of these are increased frequency, but intellectual disability is the most frequent comorbidity of them. Next question. Okay. A 5-year-old boy presents to the outpatient clinic with his parents for evaluation of abnormal speech. Parents state he has started to develop broken speech over the last several months, which is now interfering with his interactions with his peers and teachers at school. The boy's speech appears normal when engaging in pretend play with inanimate objects, but it is noted to have a stark change when presenting items to his class during show and tell. When conversing, the boy says, I'm 5 years old. He visibly struggles during speech with noted grimacing and eye blinking, but otherwise appears to be growing and developing normally. Which of the following conditions is the most likely diagnosis?
Hey, one.
Okay. So this one's a tricky one, honestly, just because these all seem kind of similar. But the answer is childhood onset fluency disorder, which is also referred to as stuttering, is a communication disorder that involves the repetition or prolongation of speech sounds, hesitations before and during speeches, long pauses in speech, effortful speech, and or monosyllabic whole word repetitions, typically accompanied by anxiety about speaking, and can place limitations on how comfortable a child feels in participating in social and academic environments. Like I said, this is difficult because a lot of these really overlap and it's just little nuances, but social communication disorder makes it difficult for people to use verbal and nonverbal communication. It's more like actually an issue with forming language and with pragmatics. So this was like, you know, specifically stuttering, while social communication disorder would have a different approach to like how they were processing words. It would be, and it would be more generalized.
That's
And also nonverbal communication as well, while this one was just verbal. Social anxiety disorder causes people to have an intense fear and persistent fear of social situations. And while you might have some speech difficulties due to social disorder, it does not encompass the speech difficulty. And then Tourette's disorder, sudden uncontrollable repetitive movement and sounds called tics, blinking, shrugging, coughing, or vocal such as grunting, sniffing, saying rude things. The main thing is that it just manifests a bit differently than this. It's not as much specific to these situations, and the tics tend to be a bit different than the how his speech was. And I see how that could be confusing with kind of the eye grimacing and blinking, but it just manifests a bit differently. And then selective mutism is where they don't speak at all in specific situations, which was not the case here. Okay. Question number 5, a 9-year-old child with ADHD, it does not respond to methylphenidate. Which of the following medications should be tried next? Okay. So the correct answer is E, dextroamphetamine. Looks like most of y'all got that right. The main thing is when treating ADHD, if one stimulant fails, it's generally recommended to try a second stimulant medication if the first one isn't effective before switching to a non-stimulant options. And then, of course, I've just got some basic method of actions for these medications. Dextroamphetamine is a stimulant that works by increasing dopamine levels in the synaptic cleft by stimulating release from presynaptic cells. Methylphenidate, on the other hand, blocks dopamine reuptake, theoretically has less addiction potential. Clonidine and guanfacine are alpha-2 agonists, so they're the non-stimulant options for ADHD treatment. And then there's a little bit of their differences in their receptor profile. Prozac is an SSRI and is not typically used for indicated for ADHD. And then bupropion is usually used as an antidepressant. Can be used off-label to treat ADHD as well, but it's not usually chosen as a second option. Okay, question number 6. Over the last 6 months, a 10-year-old child has been exhibiting anger and temper tantrums. The child has been deliberately annoying others and blaming this behavior on classmates. This has led to multiple disciplinary actions at school. What is the most likely diagnosis? Okay. So the answer is actually oppositional defiant disorder. This one's kind of like that other one with the speech there. Everything's kind of similar, so it's just kind of little nuances, what makes it a little difficult. Oppositional defiant disorder is a behavior disorder where children show a pattern of uncooperative, defiant, and hostile behavior towards peers, parents, teachers, and other authority figures. The main thing that is related to this is how the child has been deliberately annoying others and blaming this behavior on classmates, which is much more related to ODD than the others. Conduct disorder is kind of like an escalated version of ODD, but conduct disorder goes beyond just getting in trouble. It's more being outright abusive, hurting animals, skipping school. It's a much more extreme and antisocial, aggressive. Meanwhile, the others, intermittent explosive disorder is usually you're okay, the kid's okay, but then something happens and it's like sudden repeated or outbursts of anger or verbal outbursts, which wouldn't be as much involved with deliberately annoying others and blaming the misbehavior on classmates. Behavior tends to be short-lived once the tantrum subsides. ADHD, none of y'all picked that, but it doesn't necessarily involve any of this. Sometimes they're often comorbid, and then DMDD is ongoing irritability, anger, frequent intense temper outbursts, which kind of overlaps with intermittent explosive disorder, but the main thing is that I think DMDD is kind of more ongoing irritability and anger with frequent outbursts, while intermittent explosive disorder, when they're not having a temper tantrum, they're more normal. When they are, it's more extreme. So there's more a night and day difference with IED compared to DMDD, which is more ongoing. But DMDD does not involve but deliberately annoying others and blaming this misbehavior on classmates. It's more just being really grumpy. Okay. Question number 7. Adverse childhood experiences, or ACEs, have been associated with higher odds of developing many physical and mental health problems in adulthood, even with an even higher risk in people with multiple of them. The association is strongest between 4 or more ACEs and which of the following outcomes? Okay. So looks like, it was split, but a good amount of y'all got it right. The answer is suicide attempt. So, adverse childhood experiences, have a large impact on a lot of both physical and mental health conditions. Here's a lot of the examples, various types of abuse, neglect, household dysfunction, and the more of them, the worse a lot of the outcomes are. It can increase these behaviors. So the thing about this question is most of these are increased, if not all of them. It's just which one is the strongest association, and the strongest association is suicide attempts. Question number 8. Which of the following changes is usually the first pubertal sign in genetic females? Okay. Looks like most of y'all got this right. Formation of breast buds. So Tanner stages, another thing like the child developmental stuff that you kind of got to memorize. It honestly, a lot of these, it was a little inconsistent with the breast buds versus the development of pubic hair. But breast buds tend to come first, just something to learn. And for males, there's a question, it would be enlargement of the scrotum and testes. And then these are the other ones. So this is just kind of something to memorize. Oh. And yeah, here's another example of the Tanner stages. Question number 9. A meta-analysis of multiple clinical trials found a modest increase of suicidality when adolescents were treated with each of the following agents. Okay, so it looks like most of y'all got this right. Yeah, the answers are SSRIs. You learn about the black box warning. But something of note. So yeah, in 2004, the FDA mandated a black box warning on SSRIs, saying they may increase suicidal ideation and behaviors, though not necessarily completed suicide, in children, adolescents, young adults. But however, there's, some issues with the study. It's confounding by indication, early study design. It's a relatively rare event. There's, what's important is the need to balance small potential risk and suicidality with untreated depression, which itself is a risk factor for suicide. And, generally, if they really need it, it's better to go ahead with the risk and just to, the really low risk and monitor just closely. As for why there's an increase in suicide risk, there's a lot of potential, speculation. Some think, it might be that people with bipolar disorder that haven't ever manifested a manic episode may respond worse to the SSRI. And then there's some where thinking that they are too low motivation at first, and then just the slight amount of energy when first starting it gives them the energy to actually complete it before that, or go and attempt or have the behaviors before they end up getting better. But, and this is kind of, I think that there's a lot of confounding variables with this chart because, during this time was also like the onset of like social media, stuff like that. So there's, a lot going on. But it's noted that actually after the black box warning, there was actually an increase in, suicide attempts. Or suicide rates. So untreated depression poses a significant risk for suicide, and undertreating children and adolescents with severe depressions may be causing unintended harm. And this chart may be contributing to this chart. Okay. Last question number 10. Which of the following neuromental development aspects of the adolescent brain is most closely linked to poor judgment and impulsivity? Can y'all see the question? Okay. Okay, so the answer is incomplete myelination. A lot of y'all pick decreased neuronal pruning. Pruning is actually something that happens in late adolescence and early adulthood that helps with the development of this. But it's not a decreased amount in the adolescent brain. It's something that does occur in late adolescence and young adulthood. So, in the teenage brain, a lot of areas of the brain are not fully developed and not fully myelinated, like the prefrontal cortex. Because it's not fully myelinated, it's prone to high-risk behavior because it's not fully able to process judgment. The amygdala is more impulsive, and teenagers use it more than adults do. So there's a lot of areas that are just not fully developed that lead to more impulsive behavior. Okay. Does anyone have any questions? Okay, no, thank you.